If you are interested in learning about the scientific side of ketamine treatment for mental health, this is the episode for you. I have been curious about this for some time, and then I was able to interview Dr. Mark Hrymoc, and he is a psychiatrist in Los Angeles, and we had a great discussion about ketamine treatment and why it can help with treatment-resistant depression, anxiety, trauma, and other mood disorders. Now, of course, we also discussed a lot of other issues such as substance use, different medications, different treatments, and how these all intersect with the fields of psychotherapy and psychiatry. So I believe you're going to love this interview with Dr. Mark Hrymoc, and he's a double board certified psychiatrist in general psychiatry and addiction psychiatry, also known as addiction medicine. He has extensive expertise in the psychopharmacology of addiction and mental health disorders, and he practices in Los Angeles. All right, let's get to the interview. All right, welcoming to the podcast, Dr. Hrymoc, MD. Thank you so much for being here.
Yeah, thanks for having me, Paul.
Yes, and for those at home, I, of course, said his name is Mark Hrymoc for the bio that I just read. And joining us from the Los Angeles clinic, the Ketamine Treatment Center in the Cedars-Sinai, one of the Cedars-Sinai's medical buildings in Los Angeles. I appreciate you being here to talk about ketamine. But first, probably we're going to talk about addiction. So can you tell us just a little bit about what you got you into working with the folks dealing with addictions?
Yeah, I first became interested in addiction, honestly, in college. I took a work-study job, a part-time job. I knew I was interested in psychology already. I saw an ad for a research assistant at a treatment research center. And so that was in the mid-90s. So at the very beginning of my educational trajectory, I really learned about addiction as a treatable medical condition that had treatments that could include therapy and medications, and often both. So from my earliest academic age, I really took to that field, really liked it. Then I went to medical school, really loved my psychiatry rotations that I did, went on to do a psychiatric residency and then addiction psychiatry fellowship at Cedars-Sinai. And I started my practice there at this point 20 years ago. So.
Wow. Okay.
Mm-hmm. And over the years.
Go ahead. Yeah, tell us more.
Over the years, I have worked at a number of drug treatment centers. I've done many detoxes, and I currently work in an outpatient setting. So not in a treatment center, but have my own patients that see me every week or month or a few months to work with them on mental health issues that could include addiction, often include depression, anxiety, insomnia, because addiction doesn't occur in a vacuum. And I help people with any of those conditions.
Okay. Yeah, excellent. Sounds like you've got quite a lot of experience in this area. If you've been listening to the podcast, I worked primarily in a substance area of folks dealing with substance use issues for a while. Now I do all types of things, a lot of trauma treatment. But I'm glad we have you as an expert to kind of talk about some of the myths that still are pervading the mental health system, both in psychiatry and in the psychotherapy realm. Of course, the first myth that I wanted to bring up was the sobriety first myth, which, if I can sort of pontificate on that, is sort of this belief that if you've got depression or PTSD or anxiety or whatever's going on, we got to clear out your system first. You got to be completely sober. And when you finally kind of dealt with the 12 steps or whatever, then you can come in and get, healing on the reason why you might or might not use. What are your thoughts on that?
Yeah, that approach doesn't work. It's not ideal. Ideally, we try to do a full assessment where we not only look at the addiction issues, but also mental health issues that may have triggered the addiction in the first place, or cause it to continue to be an issue. So for many people, it's depression, anxiety, and insomnia. And a lot of times, substances are a person's own best attempt to self-medicate. Clearly, alcohol and other drugs are not the best medicines for mental health issues, and that's often where people run into problems. So they both need attention simultaneously. They both deserve a treatment plan.
Yeah, I agree completely. I do think my opinion is that that sort of sprung out of some old school thinking about mental health and substance use, and these sort of derogatory way that for years people who was struggling with substance abuse or substance use issues were treated and talked to. I was trained in the community reinforcement approach method, which kind of grew up with the motivational interviewing crowd in the University of New Mexico. And of course, when you're working with kids or adults, what they learned from their studies in the 70s and 80s and then in the 90s was a lot of people wanted help, but they sort of viewed themselves as a user or a loser or an alcoholic or whatever. They had this negative self view, and they also had kind of stopped doing a lot of things that made them happy in their life. And so obviously in conjunction with psychiatry, we would work on trying to help them find joy and positive things in their life while working simultaneously on the substance use issues. And then eventually, usually we uncover all sorts of trauma and depression and different things that were going on. And instead of kind of not, some people did need to go to detox and go to zero on the substances, but if it was a different sort of substance, we would, it would kind of be more of a gradual transition.
Mm-hmm.
So tell me about your approach with folks getting like a full treatment plan versus, just like, oh, we need to treat this single issue.
Yeah, I mean, I'll simultaneously ask about their substance issues and when it first started, to use the example of alcohol, like when was your first drink? When did it become regular in any way? When did it become problematic? And where is it at now? So the course of their relationship with alcohol and what they want help with, because that's also vital to have a person's buy-in on what needs focus and what the goals of the treatment are going to be. And then I'll do an exactly analogous set of questions about depression and anxiety and any other mental health issues to see, like, when did it first start? When did it become an issue on any regular basis? And especially, how does it interfere with their lives now? Knowing that there are substance-induced mood issues like alcohol-induced depression, for example, and that might be part of the reason people sometimes will justify like a sobriety first standpoint, but it's only through a series of questions that you can actually determine that maybe this person's depression preceded their alcohol use, and they might describe a significant depression in their teenage years until they discovered alcohol in their late teens or 20s, and that's when they kind of took to it like a duck to water, and it was off to the races after that. So that's the general approach, and just kind of getting a good history and trying to suss out chicken and egg, what caused what. We don't always know what caused what. There is a large genetic contribution to both mental health issues and addiction. And actually, the statistic is 50% of mental health issues like depression and anxiety are genetic. And for substance issues, it's 60%. So addiction is even more heritable than mood issues.
Yeah, I glad you brought that up, because that's sort of what we see in the clinic. And it's like, whether that we're fighting over the chicken or the egg, we should just be helping the person. So you're kind of, what I see is you're trained in more of a modern modalities, which are the person-centered approach, the client-centered, where you really look at the person as a holistic person and not as a label, right? And so,
Right.
but while educating them and disarming maybe some of their defenses around the substance use, like, hey, this is what's going on. We're trying to help you. So let's, suss out what's happening here. And
Mhm.
also, obviously, there are many interventions, especially with alcohol, that I know about, that you could use pharmaceutical interventions or different types of titration to help the person reduce their use, which could then possibly help with if they're having mood-induced alcohol, um, or what is it? Alcohol-induced mood disorders. There we go.
Yeah.
Yeah, because and I mean the newer research coming out on that with alcohol and all the medical journals is that it's disrupting so many processes, including sleep and your gut microbiome, which can then lead to, like, as you said, like the genetic contributions can then kick into play there. I'm not a scientist, but I understand that these things work together and they don't work in silos. So tell us a little bit about the feedback loop, how like PTSD and anxiety are like acting as a fuel. Like, I need substance because of these things. I'm self-medicating in a way. Can you explain kind of what that means?
Yeah. I'll often ask, yeah, tell me about your drinking, and how it even came to be. And the usual description is they may have had some issue, so like anxiety and panic attacks, let's say, that where they realized if they have a drink or two, it just kind of takes the edge off and therefore becomes reinforcing because a person is in an unpleasant state. There's mental pain that they're feeling, and then they pour alcohol on top of it, and that pain goes away. So, that's like a conditioned learning, almost like Pavlovian type of learning, where people associate then alcohol with relief of the pain that they're in. And if they have an anxiety disorder, like panic disorder or generalized anxiety, then they potently start to associate alcohol with relief, and they might get into a pattern of even daily drinking if they have chronic daily anxiety, or if they have panic attacks once a week, then they might binge once a week to, quell those panic attacks. And so I do take that person-centered approach and learn like about the propensity that a person has to even medicate their own symptoms in an effort to try to inform me what might be effective medications to help them. So, alcohol happens to be chemically similar to benzodiazepines like Xanax, Ativan, Valium, Klonopin. And so it's not a coincidence that alcohol seems to help people with anxiety issues, but it does not make for a good medication because it also causes intoxication and it causes tolerance quickly, and very quickly causes more problems than benefit. But to even bond with the patient, it helps for me to identify, like, yeah, alcohol helped you, or at least for some period of time it helped you, and then it turned on you. And they'll often really identify with that line of thinking because that's been their experience.
Yeah, I like that. And yeah, I think the old school approach is alcohol is bad. I mean, it comes even out of the prohibition movement, where if you've read anything about the history of the US with the prohibition movement, how there's this massive, like, if we could just stop the alcohol, we'll stop all these problems, right? When there was, we were still evolving as a society. But like you said, alcohol, I also, well, I've read that alcohol is a dopamine agonist. So, in addition to kind of quelling short-term anxiety, if you're not heavily using it as a dependence, it can make you just feel happy temporarily, and
Mm-hmm.
then there's a massive crash and a fall off, and then you get all the. Not everybody gets this, but a lot of people get the mood issues the next day or the next week, right? So,
Yeah.
um, and kind of walking people through that, which is a scientifically based thing that at first is helping a little bit, and then it started getting worse because you needed it to feel good, right?
Right. Right.
That
And then
is
they may
a
even
lot of
have
people's experience.
withdrawal. They
Oh,
may even have
withdrawal,
withdrawal.
yes.
If they
So,
stop drinking, then their body kind of rebels and has even rebound anxiety worse than before, shakes, sweats, things like that.
oh yeah, depending on the amount of use. So, I mean, yeah, it's important to know. I think with a client or a patient in your office, you're treating them like a person who was doing the best they could at the time, And the best and the most easy, one of the most easy accessible things to immediately make you feel different is throwing a drink back, which takes 5 minutes. And in fact, the alcohol industry, which isn't doing so hot these days, thanks to the marijuana industry, was in the last 15 years really ramping up the accessibility and the flavor of these alcohol drinks. So they were having all these cans, and in fact, the cans looked like energy drinks. And in fact, there was mix-ups where people thought they were, it's like a long story, but people at the gas station were buying what they thought was Celsius, and it was actually Truly. It's a whole thing. But what I'm saying is they were kind of preying on this, I think, my opinion. I don't want to get sued on that, but I think it was the marketing of like, hey, you don't have to go get a nasty beer. You don't have to go mix a drink in your office with a, stir stick. You can just grab one of these cans that has got alcohol in it with a bunch of fruit flavors that barely tastes like alcohol at all and just chug it real quick. And people were, that was, I think, increasing sales for a while. And it seems fun for a while, and then it happens. So, and that's where you wrote meeting people where they're at. You were talking about that. So, and harm reduction. So the concept of harm reduction, of course, is controversial depending on who you're talking to. I don't think it's controversial, but, I'm not in the AA circle. So can you talk about that?
Sure. The general premise of harm reduction is a acknowledgement that reducing the harm associated with a person's substance use is already a success. And if we can even get a person to reduce their substance use, especially the problematic ones, we'll take that as a win. Maybe we'll have the ultimate goal of complete abstinence, or on some level recommend complete abstinence for a person really to bring their level of harm down to zero. But and any less harm that a person can have related to substances, the better for the patient. And that's really what we're there for.
Excellent. Okay. So before we get into a little bit about dual diagnosis, I do want to know more about your clinic. And so you're doing psychiatry in this clinic with multiple other doctors as well, or is it mostly just you?
Yeah, there's 12 psychiatrists total, and everyone has various specializations. There's some child and adolescent psychiatrists, some geriatric psychiatrists, and a few addiction psychiatrists like myself.
Okay, excellent. And with that, you obviously are integrated to the point where you can help somebody that maybe if you find, okay, it's not my specialty, I can pass this off, this person to a colleague who might be a better fit.
Right. If I'm treating someone, they might have a family member, grandparent, child, spouse who can benefit from seeing another psychiatrist. And so, we can refer in that way.
Excellent. And so that's good to have a lot of people in the same space. I work in a group practice as well, and I find I'm in a group practice as psychotherapists, and we find that very useful because we can share tips. And if we find somebody that's like, okay, there might be a better match with this person, we can recommend that as well. But you also do ketamine as a psychiatric way of treatment. So ketamine is, of course, has been kind of gathering up some headlines in the past 5 years. Can you kind of talk to us a little bit about how your clinic uses ketamine with clients?
Yeah. Ketamine is a very old medication. It was FDA approved in 1970 for the treatment of pain and also to be used in surgical settings, emergency settings when sedation was needed. But there was research done in the early 2000s that demonstrated it also works as a very fast-acting antidepressant. And in psychiatry, there are a number of different antidepressant medications, but none of them work quickly. They'll often take up to 4 to 6 weeks to work, maybe as soon as a week or two if you're lucky, but it was found that ketamine often works with only one treatment and therefore very quickly garnered a lot of interest because we need fast-acting treatments in psychiatry, and ketamine also is a very potent treatment. It has actually a higher effectiveness rate for treating treatment-resistant depression than traditional antidepressants. So if a person has tried a few antidepressants and they were just never able to find anything that worked really well for them, or they always had side effects with them before, then ketamine is an option, and it belongs to a class of treatments that are called interventional treatments in psychiatry. So they're procedures that actually treat depression and other mood issues as opposed to just a pill every day. So in that same category are TMS, transcranial magnetic stimulation, and ECT, which is electroconvulsive therapy or shock therapy.
Okay, yeah, I think based on my anecdotal evidence, I'd prefer ketamine over ECT and
Yeah.
possibly TMS. I mean, I've heard mixed reviews on TMS. Some people think it's great, and other people said it didn't work for them. But I guess it also depends on the etiology of the depression and why that depression sprang up. But one thing I've been hearing about, you're talking about ketamine for depression. A lot of people are talking about ketamine for post-traumatic stress disorder and trauma with the
Mhm.
psychotherapy assisted component.
Yeah.
um, I'm curious about your use of that. I think you do that is available, but I also want to know. Well, start with that. What do you guys do with it? Kind of the integrative model,
Yeah. I was mentioning depression because that's what most of the research on ketamine, especially the initial research that came out,
right?
was its use for treatment-resistant depression or treatment-refractory depression. But there is emerging research in it helping with a variety of anxiety disorders, which includes trauma and PTSD. So in our clinic, because I'm a psychiatrist, we are psychiatrically oriented. We do that full assessment of a person and recommend perhaps ketamine, maybe other traditional medication treatments as well. They need something that helps with sleep or something that's like a spot treatment or fast acting treatment for anxiety. We can recommend and prescribe those. And there's also the option for ketamine-assisted psychotherapy, which includes a therapist sitting with the person during their treatment. So they guide them through their 2-hour experience with ketamine and also do traditional therapy during that time, in addition to just making notes about what they said, how they said it, to bring up in later sessions. So there's a emerging model of psychedelic assisted psychotherapy where there's not just traditional talk therapy once a week for an hour, but there's therapy surrounding a psychedelic medication experience, which ketamine is considered also. It's both a dissociative and a psychedelic.
I did not realize it was considered a psychedelic. That's
Mhm.
news to me. What do you know why? Because I knew it was
It's
definitely
yeah, it's
dissociative.
not a traditional. So yeah,
Yeah.
if you think of psychedelics, like the traditional psychedelics are the ones that work on the serotonin, usually 2A receptor. So psilocybin, LSD, DMT,
Hmm.
things like that are in that category. And then there are the non-traditional psychedelics, which include, a variety of dissociatives, so like ketamine and nitrous oxide, like laughing gas, if
Oh
you ever
yeah.
had at a dentist office, those
Oh
are
yeah.
dissociative psychedelics, MDMA, ibogaine. So those are not traditional psychedelics, but still considered psychedelics. So yeah, ketamine being a dissociative means that it induces a state of like disconnection or dissociation from the body. I'll describe it to people like, you're feeling kind of light and floaty, and you may feel like you're drifting a million miles away during the treatment. You may even forget that you're in a doctor's office, that you're just immersed in your thoughts, like daydreaming or lucid dreaming, sometimes patients call it. And then after the medication stops going into your system through the intravenous drip that the ketamine is delivered by, then they kind of slowly come out of the effects of it, which takes like an hour or so to,
Mm.
feel kind of good enough to get up and leave the office.
Okay. Yeah. Excellent. And um, in terms of the psychotherapy component, I was thinking about it in a couple of ways because you're talking about all the scientific pathways, but I was thinking of it in depression, and this is, more from a psychotherapy lens, but with depression, you often have this sort of a sludgy pattern of thoughts that are kind of circular, that kind of continue to, I don't know, I call it circling the drain, and often very negative. And then you can kind of have that people have anhedonia, where they kind of quit doing things that make them feel good, which then contributes to more depression. And then you kind of have the just sometimes negative self-image, worthlessness, despair, and I'm always going to feel like this. And when I've talked to people that have done the ketamine therapy, it seems like it's like almost like a massive disruptor to the system, and it's disrupting those thoughts, so they're able to kind of see it from a different perspective.
Right.
Thoughts on that? I mean, I'm just kind of waxing.
Yeah, I'll often say ketamine works both biologically as a medication, but also experientially. Like there is an experience there, a person has a different perspective on things. That dissociative quality, I think, actually helps a person who is dealing with something painful in the way that an anesthetic can just help numb something so that it can be addressed, in psychotherapy, where the tool is our words as opposed to like a scalpel being used in surgery. But a lot of times people can think about painful experiences as a lot more objective, almost as if happening to a person outside of themselves. You can ask them questions like, how would you help that hurting child within you, or that how would you help even yourself go through this? What would you tell yourself now, kind of thing? And people can talk about things more easily often with ketamine in the system than in their ordinary state of consciousness, where they might reflexively push it down, stuff it away, repress. That then makes it tough to address or do anything about. So that's another potential use of ketamine, besides even like depression, anxiety, like those disorders or labels, diagnoses, is as like an augmentation agent in psychotherapy. It may help therapy be even more potent through helping people be able to look at things in a different way.
Yeah, it gets past a lot of defenses and habits and whatnot pretty quickly. Yeah. And then obviously the biological component is happening. So especially with, like you said, the treatment-resistant depression or like really persistent PTSD or anxiety, I do think it's an excellent tool. So that being said, how many treatments do most folks have? This is very anecdotal, but like when you come in for ketamine, it's like, hey, I've come in for ketamine. I'm trying these other meds. I'm seeing a therapist. Like how many, like I've got depression. Let's say I've got treatment-resistant depression. That might be somebody who's like really in need of that, versus like maybe somebody who just had a really bad experience a few months ago and they're like, I can't get this out of my mind. I've tried different treatments. What are your thoughts on kind of the different profiles of patients, from the chronic depression to like an acute issue?
The standard way to start ketamine treatment is with the induction series, which is delivered as 6 treatments over a 3-week period, at least 1 day apart. So I think of that as just the initial, more aggressive intervention to help a person get out of whatever hole they're in. Ideally, we see close to 100% resolution of symptoms, them feeling completely better after the 6 sessions. And then we go to like the second phase of treatment, which is trying to figure out what's the maintenance dose, right? So ketamine is a treatment. It's not a cure. After that initial round of 6 treatments, then there will be some need for maintenance treatments. I'll tell people to expect to need another treatment every few months, like 2 or 3 months, basically. Some people might need it only every 6 or 12 months, others every month. But yeah, the usual is kind of like on a quarterly basis. And really does help a lot of people when things like haven't helped before, or if they've had side effects to other medications. It is a treatment that's delivered. And it's more than just the medication being in their system. It actually does last for, like I said, months at a time.
Well, yeah, so it sort of seems like the reset idea, right? And that's
Mm-hmm.
why I think they're studying, Johns Hopkins is studying psilocybin, and they're giving people these large doses of psilocybin, which seem to sort of reset things. But how often does it come back? It sounds like what you're seeing from the pathways of ketamine plus the psychological effects. Certain people don't need it; they don't even need that much. Do they need? I mean, I guess you can't talk about certain patients on the air, but it seems like it starts off more aggressive and then becomes like you said, like a quarterly thing, hopefully, or less, depending on
Right.
the person. So, um, well, that sounds very promising. Um, what about? I guess this. It's kind of up to. Is it up to the patient to decide they want to try that versus like, hey, you know what? Here we can just try you on a couple of medications. Go see a therapist once a week. Try these SSRIs or SNRIs. What's kind of your approach to figuring out? Do they just need a traditional psychotherapy med with therapy, or sorry, psychiatric med with therapy, or try to ketamine? How do you suss that out at your clinic? I'm just kind of curious.
Yeah, for depression, anxiety, PTSD, in general, I do recommend they try an SSRI first, just because they're very safe. They're often effective for at least 2/3 of people get benefit from a regular antidepressant pill. And of course, the ketamine treatments is not a trivial thing. It is a procedure. You have to set aside the time to come to the office for the 2-hour treatment. 6 times in 3 weeks is, like I said, the evidence-based intervention schedule. And it's something that they'll need to continue to get to. Financially, insurance often does not cover ketamine treatments. The one exception actually is Kaiser Permanente. I've learned, a very forward-thinking organization, physician-driven, data-driven, and clearly the data is great on ketamine being used. So they're like the one exception, but most major commercial insurance providers do not cover ketamine because it's technically not FDA approved for the treatment of depression. Like I said, it was FDA approved for pain and anesthesia applications in 1970. But because it's a generic medication, there's no pharmaceutical company that has the profit motive to do the millions of dollars worth of research to get formal FDA approval. So it's never going to happen. But a lot of psychiatrists will recommend it because they know that it works. It works quickly, often after just one treatment, and it's really well tolerated. So unlike TMS, it's 5 days a week for 6 or 7 weeks. I mean, it's just a huge time commitment for a person to get TMS. ECT often is a kind of a last resort type of treatment because that can really, the treatment itself can disrupt your life for like a month and has a lot of memory and other side effects. But ketamine is, really well tolerated. People actually like find it subjectively pleasant, and also happens to be a treatment that really helps and helps quickly. And they can often get off of other medications that might be causing side effects too.
Well, it's good. I'm actually more curious. So you guys use the drip method, but of course, in the US, whenever something gets released, there's a trove of competition. And I've seen and I've heard of this. I don't know if it's actually legitimate, but there's companies that apparently will do some sort of thing where they'll ship you ketamine pills and then you have like a therapist online. This sounds terrible, but can you explain to me the difference between the pill method and the drip IV?
Yeah. I mean, I'm familiar with all routes of administration for ketamine, and there could be a time and place for alternative administration routes as well. IV is the gold standard. That's what has all of the best research on, double-blind, placebo-controlled studies in medicine are the types of studies that doctors will need to see before actually recommending a treatment to patients. So that exists for IV ketamine, but not for other routes. Those other routes are an extrapolation of the benefit that we see with IV being thought to be conferred to other routes of treatment. So in order of potency or like bioavailability, like the amount of medicine that gets into your system with IV, it's 99%. So basically all of the medicine that you give to a person intravenously gets into their system. If a person has bad veins or just doesn't like the idea of an IV sitting in their arm, then we do give, and many other psychiatrists will give like an intramuscular injection of ketamine. So basically, like a shot in the arm, just like where you might get a vaccine in your shoulder. You can deliver ketamine as well, and that way 95% gets in the system. So pretty close to 99, not exactly 95. It's also not a slow drip. It can make for a slower onset experience initially, but then it is more potent and hits a higher blood level when it peaks, which is usually like 15 minutes after the injection, and then it can taper off pretty quickly. So the IV tends to be better because not only is it evidence-based, but it's a slow drip. You can pause it. You can't take back an injection once it's given.
Yeah, very good point.
And then below that are there is an FDA-approved form of ketamine called Spravato, which Spravato is a purified form of ketamine. So it's S-ketamine. If we think of generic ketamine, it's R and S ketamine together. If you think of like a basket of gloves, whenever any molecule is made in a lab, there are both right-handed and left-handed versions. Mm-hmm. And so S-ketamine is, let's say, just the right-handed version. So this is a trick that pharmaceutical companies will do to modify a molecule enough that will enable them to get a patent on it. So that's why Spravato actually is covered by insurance, but it is a less potent form of ketamine. With Spravato, only 45% gets in the system. It actually takes a few weeks to separate from placebo on research studies, whereas with IV ketamine, it is a faster acting and more potent treatment even than Spravato. But yeah, we'll give Spravato in our office too. And then the last one are the generic troches, they're called. So they're like dissolvable tablets or sometimes wafers. And that's what you're referring to, that yes, with the pandemic, there were a lot of regulations about controlled substances needing to be prescribed in a face-to-face office setting that got suspended. And so that created this opportunity for a lot of corporate players to rush in to, I guess the cynical way of looking at it is to be able to just ramp up the sale of controlled meds over the internet. So that happened with stimulants like Adderall for the treatment of ADHD, and it's happened with ketamine too, where there are companies that will still say that it's treatment. With a troche, it's 25 to 30% gets in your system, so it's the least potent way, but it still is ketamine. You still get a blood level, you still get an experience, and their thinking is that at least this way, their sell is that it maybe is destigmatizing and convenient. A person can never set foot in any medical office, but it's interesting that advertising medications to consumers is actually illegal in Europe, but it's fully legal in the US. And so it does create this kind of cart before the horse situation where you have patients choosing medications for themselves, and then it's on a provider just to kind of confirm it, rubber stamp it, as opposed to a more traditional model, I'd say a more responsible model where a patient comes in with a symptom, not necessarily an agenda on how to treat it, and then it's up to the doctor or nurse practitioner to assess what's the best way to treat them.
That was a very good summary, and yeah, you've harped you touched on a slight issue, which is a major topic of my podcast, which is the medical system and how we can improve it, and of course the negatives. It It is difficult. I am encouraged by the idea of the ketamine in the office and the hardcore, let's go for it, 6 sessions, let's do this, let's see what we can do. Because I do think that a lot of folks don't want to be dependent on an SSRI or an SNRI or whatever, although those do have a high efficacy in at least most studies. Of course, the only controversy is like what happens after 10 or 12 years. You still need it. It's a whole, that's another topic that we don't need to get into. But it kind of gives people power to think, I can go do this treatment. I can select this with this person and then hopefully get some relief that I need. And maybe, kind of choose. It's like another option, basically. So that is encouraging. I do find I am excited when clients and patients find things to help themselves, but I also agree that when it comes to medications, it can be very detrimental because there are so many factors you look at when deciding to prescribe somebody medication, depending on the situation. Like we talked about substance use in the beginning, and there are certain substances, if somebody's using that and you're trying to reduce it, that certain medications may be better for, certain ones are worse. So it's important to have somebody you trust, a doctor to help you that you trust. And I think that that's a big factor for me, interviewing a psychiatrist like yourself, who I can tell understands the science and didn't just forget it all after med school. And it just says, oh, you're this, stamp, take that. You're this, take. It sounds like you really put a lot of thought and care into your evaluations and your treatment, which is important for people to understand in our system. From my understanding, in the US, it's somewhere over 60% of psychiatric medications are prescribed by PCPs, primary care providers, who do not have almost any psychiatric training. And so I will reiterate and say once again on the podcast, if you're going to get meds, please go to a psychiatrist. Take your if you're in a bad spot, I understand you might need to get something quick, but then go get an evaluation, because that could be the whole reason the treatment isn't working, or there's too much treatment, not enough treatment. And of course, there's genetic tests now that can somewhat steer what medications may work for you and what medications may not based on your genetics. But then, of course, you have this option as well. So just the same thing in psychotherapy. I say not all therapists are created equal. Find one that works for you. So any thoughts on that, as I know we're reaching the end of your hour and all of that?
Yeah, I mean, I think it's fair for primary care docs to be the front line. They're often the ones that are seeing patients over the long term, get to know them, and might be the first person the patient calls if they notice depression or anxiety, things like that. And SSRIs are very safe, and they often work. And because they take some time to work, they do serve a role in getting the medication quickly. But there's often a lot more there, like you were saying, that a primary care doc isn't necessarily going to be asking about ways of optimizing the treatment right off the bat, as opposed to waiting to see if this one medicine alone works, and then do we add on other things only after we've seen 2 months later there hasn't been benefit, with sleep or anxiety or marital issues or whatever else, like a psychiatrist can clock as a problem and make either an appropriate referral for or create some other plan for, which might include a different medicine or therapy.
Yeah, excellent. And so in terms of your practice in Los Angeles, you obviously serve people in Los Angeles, but so how do people get in touch with you? Or do you do any telehealth in California? Are you allowed to do other states? What's going on with that?
Honestly, all the psychiatrists in our office do telehealth. So we're all licensed in California. Since the pandemic, psychiatry has actually largely shifted to be a telehealth specialty.
Oh.
So, it's a form that works for most patients, especially if you think of like a follow-up visit is, 20-minute visit. This in LA, where there's a lot of traffic and parking headaches and things like that. Person can just Zoom in and out of an appointment for, 20 or 30-minute med check as opposed to needing to take 2 hours out of their day to drive and all that. So, yes, we do see people via telehealth all over California. For medications that need to be administered, then yeah, they have to be able to come to the Los Angeles area. And the main reason we actually have a physical office is to be able to deliver medications. So besides ketamine, there's also long-acting injectable treatments for alcohol and opiate addiction. Vivitrol is one. There's also long-acting mood stabilizing medications like Abilify, et cetera, that we'll give too. So that's the rough logistics on our practice.
Excellent. So yeah, if you're in California or Los Angeles, this is the Ketamine Treatment Center. Dr. Hrymoc and his associates are board certified psychiatrists, so check them out. This is a quick question. Do you have any future plans to get licenses in other states?
I actually am in the works to get licensed in New York as well. I have a lot of patients that kind of go between New York and LA, so it's something I'm working on.
Excellent.
Yeah.
Well, I really appreciate your time and explaining ketamine and, of course, how your approach to treating substance use disorders. And yeah, look forward to putting out this episode.
All right. Yeah, really great meeting you, and thanks so much for having me.
Yeah, absolutely. And there you have it. This has been another episode of the Intentional Clinician Podcast. If you are enjoying the show, please leave us a rating on iTunes or share the show with people you know. I would surely appreciate it. As some of you know, I am passionate about preventing future violence in the United States. I have started a nonprofit with colleagues called the National Violence Prevention Hotline, which is a 501c3 organization. We are endeavoring to gain funding and collaborators and volunteers so that we can start a 24/7 hotline and chat line to reach potential perpetrators before they may act violently. It is a bold effort to curb violence and save innocent lives by working to connect with potential offenders while they are in the planning stages of violence, help to de-escalate them, and provide resources so that they can get appropriate professional help. The National Violence Prevention Hotline is looking to open up a conversation about violence in society, the causes, and the solutions. You can learn more by visiting our website at violencepreventionhotline.org. You can get involved by writing your congressperson from our website, sharing it with your network, or even donating to the cause. If you are looking for an EMDR International Association consultant, I am a consultant and I can help provide 20 hours that you need to become EMDRIA certified. Just check out the show notes and send me a message and see if we're a good fit to work together. If you are in need of counseling, do not hesitate to make an appointment with a local counselor in your area. You can also make an appointment with the excellent clinicians at Health for Life Counseling in Grand Rapids as part of the Trauma Informed Counseling Center of Grand Rapids by visiting www.healthforlifegr.com. And if you are in the state of Michigan, you can also schedule a telehealth appointment. The recording you just listened to consists of the personal opinions of Paul Krauss and his guest, and while these are based upon the literature they have read and the experience in their respective fields, the information on this podcast should not be viewed or thought of as the definitive opinion on any subject. Listening to this podcast is not a substitute for treatment. If you're in a crisis, please call 911 or the National Crisis Line at 988. Support your local bookstore by shopping at bookshop.org. That's www.bookshop.org. It donates a percentage of sales to local bookstores all across the United States, which I think gives character to our cities and a place to hang out and a place to explore. You can order from the comfort of your own home online while supporting businesses near you. If you are a therapist and you are not involved in your local counseling or therapist or social work organization, please get involved to at least pay dues so that we can have lobbyists help keep mental health care accessible at the government level, and also expanding into schools and other places that need it. And also, if you didn't know,
counseling organizations and professional organizations are working to keep us from becoming gig workers for a lot of large corporations who are coming in and trying to buy up local counseling agencies or basically pay you what they pay for people to deliver food to your house. So get involved. Until next time on The Intentional Clinician, I wish you all a safe and peaceful week.